Hello, my name is Shamil Sadi, and I'm a pediatric intensivist working in Cape Town, South Africa, at the Red Cross Hall Memorial Children's Hospital. I'll be talking to you today about preventing sepsis in Africa, but really most of what I'll be saying will be applicable to most lower and middle income countries around the world. A definition of pediatric sepsis has been quite elusive. I guess it's also quite difficult to spot the child in a busy casualty with sepsis. Importantly, I think it's also important to remember that most of the interventions we do in order to reverse sepsis is time sensitive. The longer we delay optimum treatment and correct treatment, the worse the outcomes of those children will be. Christina Rudd and others put together a really elegant study looking at the global, regional, and national sepsis incidence and mortality between 1990 and 2017, looking really at a global burden of disease study. And what they did was they looked at vital statistics, mortalities data, looking at millions of individuals, and put together quite an impressive document. If we look at the burden of sepsis as to what the incidence is, if we look at mortality rates, first of all, they estimated that in 2017, there were nearly 11 million deaths, which is approximately just under 20% of all the deaths worldwide. Interestingly enough, just under half of those deaths from sepsis came from non-communicable diseases and from injuries. So encouragingly, the mortality rate has dropped from sepsis. So from the early 90s, where it was sitting at, well, it's dropped 30% between 1990 and 2017. And where are these sepsis incidents happening? Unsurprisingly, if we look at the dark blocks as being higher incidence, the highest incidence of sepsis occurs in the low and middle income countries, South America, Mexico, most of Africa, Middle East, and Southeast Asia. So it's not surprising if those are the regions that have the highest incidence rates, that is where the highest rates of mortality happens. So highest mortality rates in low and middle income countries. Now, these are the wonderful glossy photographs you'll see in National Geographic Africa, but if you look a little bit deeper, you'll see that there's usually a great divide. Time magazine described South Africa a few years back as the most unequal country, but it's probably what you'll see throughout Africa, where you have people living in abject poverty. There'll be some division, and then you have individuals with access to huge amounts of resources and wealth. And that really impacts on the healthcare services that is available for those communities. And a typical journey of a mother and a sick child in an impoverished community would be a delay in recognizing illness and seeking help. That delay translates to delay in traveling to the healthcare facility. And they'll usually arrive at a healthcare facility, crowded healthcare facility. There'll be a delay being seen, and unfortunately, most often, low quality of care. And all of those delays, unfortunately, translates into poor outcomes for that individual. A very interesting study done by Mirjana Cvetkovic in the United Kingdom, looking at the timing of death in children referred for intensive care with severe sepsis. And based in the UK, in a large regional PICU transport service, over about a 6-year period, they had 703 children referred with severe sepsis for transport. What they looked at was when these children died, and 130 or 20% of them died in the first year after the referral. So looking a bit deeper at the data, 55% of children referred with severe sepsis died within the first 24 hours of referral. And really something to take note of is that 34 children, about half to a quarter of the children who died from sepsis died before PICU admission. So this is in the UK with fairly good resources and maybe not generalizable to other countries or lower and middle income countries in terms of the disease profiles, but in terms of improving quality outcomes and educational strategies, they were suggesting that they should be directed outside of the ICU and not in the ICU. And I think if the implication would be is that in Africa or lower and other lower and middle income countries, that you'd have probably a large amount of children that would die before they even arrived at healthcare facilities. If we look at health expenditure, this is looking at 2019. Unsurprisingly, you'll notice that low and middle income countries spend less on health. If you look at some of the blues, I'm fairly surprised that South America spends a fair bit of money. South Africa spends a fair bit of money, but not spending more money doesn't necessarily equate to better outcomes, unfortunately. A lot of it is how you spend your money. Looking at global, regional, and national trends in under 5 mortality between 1990 and 2019, these are all causes of mortality. And mortality rate, interestingly enough, is reducing, fortunately, but most children die in low and middle income countries, as evidenced by the dark blue areas. Looking at associations between key interventions, so what interventions really make a difference to improving mortalities, and analysis looking at a number of countries in sub-Saharan Africa. The factors that made a difference to the outcomes in children were relatively cheap interventions: bed net coverage for malaria, water and sanitation infrastructure, vaccination coverage, supporting pregnant moms, assisting with deliveries, preventing neonatal tetanus, preventing malaria, cesarean section, oral rehydration therapy. So a huge amount of lives can be saved with relatively simple interventions. The health workforce status in Africa and low and middle income countries is also unfortunately inadequate. Ahmed et al. Looked at 47 countries way back in 2018 and 2019 before COVID, and I suspect it's going to be a lot worse now. Looking at a health workforce, looking at nurses, doctors, community health workers, laboratory physicians. They found sort of a regional density of healthcare workers of 1.55 per thousand population, which is probably a third of what the WHO's Sustainable Development Goals are recommending for an adequate health workforce. In Africa, only 4 countries achieved that health workforce: Namibia, South Africa, Moors, I think Mauritius as well. But if you look at countries with even less than 1 indices points, most of Africa is under-resourced in terms of health workforce. If we look at where the pediatricians are, I was quite surprised that South America has a number of pediatricians, but most in Africa, Southeast Asia, there are very few pediatricians. So the health systems in low and middle income countries need to change. We need to be more focused on communities, involving families, community healthcare workers with education, and allowing easier access for health for these sick children. Now, vaccinations undoubtedly have saved millions of children's lives by preventing infectious diseases. So interestingly enough, and it was evident, I think, in the COVID era where there was a lot of mistrust and vaccine hesitancy. Now, in the lower and middle income countries, it's not just unaffordable, but if you couple unaffordable vaccines with low uptake, then low vaccination areas or low vaccination coverage is going to result in increased infections. If we looked at Nick Stoop and others, they tried to look at a link mistrust in public institutions. So the darker the blue, the more mistrust there was in about 20 odd African countries. And they looked at percentage of children with none of the basic vaccinations And there was a positive association between the higher areas, countries where had mistrust in vaccinations and uptake of vaccinations. If we look at healthcare-associated infections, then hand hygiene must be the cornerstone of trying to prevent healthcare-associated infections. And it's an absolute tragedy when an unwell child develops a potentially avoidable healthcare infection. Bundles of care have been developed to prevent urinary tract infections, central line-associated infections, ventilator-associated pneumonias, surgical site infections. And if you put all these elements together, these bundles that have been created, potentially it increases the care that these children have and hopefully improves their outcome. The Global Sepsis Alliance has been the main vocal force behind highlighting sepsis and the dangers of sepsis. And they've had annual conferences for the last few years, and they've been really successful by engaging the WHO. And probably a very important announcement was at the World Health Assembly adopting a resolution to improve the prevention, diagnosis, and management of sepsis. This was way back in 2017. So from global alliance, I think there probably needs to be regional sepsis alliances, and the African Sepsis Alliance similarly emphasizes educating communities on sepsis, lobbying for change, raises awareness among social medias, but continental, countrywide, regional information needs to be shared. So some parting thoughts is that pediatric sepsis is usually associated with very high mortality rates. It is imperative that we prevent community and hospital-acquired infections. But in order to achieve this, we need stable political systems with investment into education and awareness of sepsis. We need affordable vaccines that are going to be actually delivered to children that are at risk. We need investment into healthcare infrastructure and equipment. We need to be able to train healthcare professionals and retain them in low and middle income countries. And we need to advocate for appropriate resources. To end off with, in the words of the late Nelson Mandela, there can be no keener revelation of a society's soul than the way in which it treats its children. Thank you very much.
Good day. I'm Lincoln Solomon, head of the clinical unit at Universitas Academic Hospital PICU in Bloemfontein, South Africa. Today, I'm talking about the role of social determinants of health and pediatric sepsis, emphasizing inequities and what we as pediatric critical care community are called to do. The World Health Organization defines social determinants of health as the non-medical factors that influence health outcomes. These involve the conditions in which people are born, grow, work, live and age, and the wider set of forces and systems shaping the conditions of daily life. These forces and systems include economic policies and systems, development agendas, social policies, and political systems. The social determinants of health are categorized by WHO in the following categories, which I'm not going to read, but suffice it to say that they determine 30 to 55% of all health outcomes. The 2020 Lancet Global Burden of Disease study demonstrates the unequal distribution of sepsis incidents and sepsis-related deaths. The distribution of these two indices being mirrored around the globe and concentrated in Africa, the South Americas, and Southeast Asia. Clearly, the burden of sepsis is borne unfairly by low and low-middle income countries. The Social Demographic Index, or SDI, is a composite index of country-level well-being, including indices of economic, educational status, and fertility levels. While there has been a steady rise in the SDIs among countries worldwide since 1950, there are still clear SDI discrepancies. There remain clear SDI discrepancies between countries. When stratified by SDIs, sepsis incidence and mortality shows a clear disproportionate burden among those countries with low SDI, while higher SDI countries experience less of a burden or mortality rate associated with sepsis. Furthermore, the young and the old are also disproportionately affected by sepsis mortality, as illustrated here. What is known about SDOH and sepsis management and outcomes comes from mostly high-income countries, as this review demonstrates, along a continuum of care from pre-hospital to ultimate hospital discharge. The author's key findings include the following. Children who are uninsured compared with those with insurance or private insurance are less likely to be admitted to PICUs in the United States of America, but have greater odds of dying compared to children who have access to private medical insurance. Children from poor neighborhoods are more likely to be admitted to PICU than those from more affluent neighborhoods. And children who are Black or Hispanic have greater risk for PICU admission and in-hospital mortality than white children. Among children with trauma, specifically traumatic brain injury, excluding non-accidental injury, uninsured children had a greater odds of dying, while children from minority racial and ethnic background had a lower odds of being admitted to PICU and greater odds of dying compared to white children. Among those with sepsis, specifically, while uninsured status, neighborhood poverty level, and racial or ethnic minority status made no difference to PICU admission rates across those categories, the odds of in-hospital mortality was greater than their counterparts. Authors of this review therefore devised this conceptual framework for how socioeconomic and minority populations experience inequitable access to and quality of care, which ultimately leads to disparate outcomes among these children compared to their more affluent and white counterparts. Importantly, they make recommendations for interventions to mitigate these disparities. Therefore, they suggest or recommend that in terms of pre-hospital or community care, improved CPR awareness and access to appropriate CPR and transfer to hospital is required. On admission, we need to ensure equitable access to medical insurance and equitable access to quality care. In hospital, we need to improve communication with families to facilitate an improved experience of these families in terms of ICU quality of care. Specifically for researchers, they recommended that we improve participation in critical care research by acknowledging and confronting researcher bias, but by ensuring representative research populations and appropriate subgroup analysis. We need to address methodological issues in critical care disparities research. We need to ensure that appropriate analysis of associations between disparities and illness severity are highlighted. We need to capture accurate socioeconomic status data. We need to identify mechanisms underlying health disparities, and we need to identify the levels at which disparities arise, either individual provider in terms of bias, hospital, or regional healthcare systems. Did a review of 102 articles on behalf of the Pediatric Sepsis Definition Task Force, none and others, found that about 1/5 of these studies did not report SDOH variables among any of the WHO categories. Of those that did, there was inconsistent and incomplete reporting, and those two studies used the same definitions. Again, literature from low and middle income countries were largely underrepresented. They conclude that researchers have a collective responsibility to design studies to include SDOH variables so as not to perpetuate implicit and explicit biases regarding minoritized groups, and to ensure consistent and standardized collection and reporting of these variables when conducting future studies in pediatric sepsis. Considering these two and other studies, Dr. Akbeko, in a thought-provoking editorial, asks the question, what stands in the way of making equity a core component of our practice and research? She brings to us three challenges as a caring scientific community: that we explicitly acknowledge the current unjust differential in outcomes, that we be careful about how we frame, formulate, and carry out research, and with whom we carry out research, so as not to perpetuate the current inequities, and that we are required to actively dismantle unjust organizational structures within which we work and do our research. And finally, for all of us, we can prevent sepsis and improve sepsis outcomes in children as we recognize the role of social determinants of health and advocate for social justice, equity, and transformation. And I thank you.
Early recognition of sepsis at the ER. My name is Stefilia Tsugutwani. I'm a critical care nurse working in the intensive care unit at Chris Hani Baragwanath Academic Hospital, Soweto, Johannesburg, South Africa. Sepsis is a leading cause of morbidity, mortality, and health care utilization for children worldwide. Mortality for children with sepsis ranges from 4% to 50%. Mortality depends on illness severity, risk factors, and geographic location. Many deaths occur within the initial 48 to 72 hours of treatment. Early recognition is therefore critical for appropriate management to optimize outcome. Definition of sepsis. According to 2005 International Pediatric Sepsis Consensus Conference, sepsis is systemic inflammatory response syndrome plus infection. So under systemic inflammatory response syndrome, there must be any two of the following: core temperature with temperature of less than 36 degrees Celsius, or fever of greater than 38.5 degrees Celsius, tachycardia with heart rate of standard deviation of greater than 2 above normal, or tachypnea with respiration of greater than 2 standard deviation above normal age. White cell count either depressed or elevated for age or greater than 10% immature. So with infection, this might be suspected or proven caused by any pathogen or a clinical syndrome associated with a high probability of infection. Signs and symptoms that the child might present with are as follows: core temperature less than 36 degrees Celsius or greater than 38.5 degrees Celsius. Rigors, fast and excessive work of breathing, including shortness of breath, difficulty in speaking, clammy and pale skin, new skin rash, confusion, disorientation, and dizziness. Floppy child, unusual sleepiness or quiet or lack of play, nausea and vomiting, reduction of urine or less diaper change, feed refusal. Challenges might be as follows. There might be a delay in presentation to the hospital due to no transport money to go to the clinic or hospital, or the parents might have started the child with home remedies, or the child was taken to the clinic initially and the diagnosis of sepsis was misdiagnosed. For instance, the child going there with cough and being given cough syrup and paracetamol only. 2, there might be interventions that affect diagnosis, like this can be medical or traditional. Using unfinished medication that was previously issued, herbal medicine from traditional healer. Conclusion and recommendation. In-depth and accurate history taking is important. Local protocols should be in place in our health centers. Continuous education about early recognition of sepsis. This can be done at the well baby clinics, at primary healthcare for primary healthcare professionals, or communities might be given some flyers or doing campaigns about this. Staff members in the hospitals will also be taught about it. Thank you.
Hello, everyone. My name is Charlene Kilba. I'm a pediatric intensivist at the Greater Accra Regional Hospital in Ghana, and I'll be talking about the management of sepsis. I'll give a brief overview of screening for sepsis, initiation of antimicrobial therapy, hemodynamic resuscitation, and supportive therapy. As emphasized by the previous speakers, sepsis is the leading cause of mortality in children worldwide, and most of these deaths occur within the first 24 to 72 hours. It's therefore important that children are screened for sepsis so it can be identified promptly and treatment initiated to prevent death and long-term complications from sepsis. The screening tool should, however, be appropriate for the clinical setting with regard to the patient categories, the resources available, and the general processes of the facility. So this is an example of a screening tool. If a child has any two of the following, an abnormal temperature or a high heart rate or respiratory rate above the cutoff for the age as determined by an appropriate Pews chart, plus any one of the following: altered mental state, mottled skin or impaired capillary refill time, or significant clinical concern, then the child per this screening tool is classified as possible sepsis and the appropriate protocol is initiated. As we can see from here, all children we see with suspected or underlying infection who have a SIRS response, we would have to assess for signs of organ dysfunction and vice versa. So in children who have signs of organ dysfunction, we must also screen for infection so that we can recognize sepsis and treat it appropriately. Now, in any child with suspected sepsis, we must assess for signs of septic shock. If the child has septic shock, then we must proceed with a sepsis treatment bundle immediately. If the child does not have signs of septic shock, then we must expedite our diagnostic evaluation. And if this supports sepsis-associated organ dysfunction, proceed with a sepsis treatment bundle. In clinical settings where diagnostic evaluation may be delayed, proceeding with a sepsis bundle the decision to proceed should be taken based on clinical grounds to prevent unnecessary delays. So what does our sepsis bundle entail? We need to obtain IV or intraosseous access if we don't have one already. Samples must be taken for blood culture and any other appropriate samples for culture depending on the clinical scenario. We also would need to take samples for relevant investigations depending on the clinical setting or the clinical scenario. We must start empiric broad-spectrum antibiotics within 3 hours of initial suspicion of sepsis in children who do not have shock. And the choice of antibiotics should depend on the likely primary source of infection and the likely organisms for that infection, as well as patient characteristics such as the patient's immune competence and possible exposure to antibiotic-resistant organisms, for example, in cases of healthcare-associated infections. The choice of starting antibiotics within 3 hours is to reduce unnecessary doses of antibiotics whilst not unduly prolonging the first dose of antibiotics in children with suspected sepsis without septic shock. Where possible, we should get also a baseline lactate measurement as a serum marker for tissue perfusion. The child should be monitored for evolving organ dysfunction. And if at any point the child develops septic shock, then the child must be resuscitated appropriately depending on the clinical setting. For children who present in septic shock, antibiotics must be initiated within an hour of recognizing shock. With regards to resuscitation for shock, recommendations are in 2 broad categories: healthcare systems with intensive care and healthcare systems without intensive care. And this is based on the findings of the FEAST trial that showed a higher mortality in African children with severe infection and signs of impaired perfusion who received fluid boluses compared to those who received maintenance IV fluids. As such, in healthcare systems without intensive care, we must exercise caution with administering fluid boluses. So in these settings, if the child has signs of abnormal perfusion without hypotension and also has no signs of dehydration or ongoing fluid losses, we should not give a fluid bolus. Start on maintenance IV fluids and monitor the hemodynamics closely. And if the child remains in shock, then consider starting vasoactive or inotropic support if available. If the child has abnormal perfusion with hypotension, which is defined as a blood pressure below the limits described in the table, or the presence of all 3 WHO criteria for sepsis, that is cold extremities, prolonged capillary refill time, and a fast and weak pulse, then we should assess the child for signs of fluid overload. And if these are absent, the child should be given a fluid bolus of 10 to 20 mL of an isotonic crystalloid. After giving the bolus, we would then reassess the child for the hemodynamic response to the fluid bolus, as well as signs of fluid overload, such as lung-based crepitations and a hepatomegaly, or increasing size of the liver. The recommendation is that we can give up to 40 mL per kilo in fluid boluses if the child does not respond. If the child is still in shock after 40 mL per kilo, then consider starting epinephrine or no epinephrine. Or if the child develops signs of fluid overload even before the fluid boluses are completed. In healthcare systems with access to intensive care, any child with abnormal perfusion without signs of fluid overload should receive a fluid bolus of about 10 to 20 mL per kilo. And this can be repeated up to a volume of 40 to 60 mL per kilo in total. And if the child is still in shock, then epinephrine or no epinephrine should be started. Or if the child once again develops signs of fluid overload, anytime during our administration of fluid boluses, then the boluses should be stopped and vasopressors or inotropic support considered. Where possible, we should get an assessment of the cardiac function, so that if the shock is from impaired cardiac contractility, we can offer inotropic support earlier rather than later. Children with sepsis should be assessed for pediatric ARDS because it's commonly associated with sepsis, and they should be provided appropriate respiratory support, such as high-flow oxygen or non-invasive ventilation or mechanical ventilation as appropriate for the child's needs and within the clinical setting. The primary sites of infection should be sought, and if possible, source control. The infection source should be controlled. So, for example, if it is from an indwelling device, where possible, the device should be taken out. If there's an abscess, the abscess should be drained. And then there must be ongoing hemodynamic monitoring. If the child remains unstable, then advanced hemodynamic monitoring should be employed if the facilities exist for it. For children who remain in shock despite starting vasoactive or inotropic support, we can consider adding IV hydrocortisone. We must also pay attention to the nutritional needs of this child. Hypoglycemia must be avoided, and appropriate dextrose-containing fluids provided to the child who is critically ill to prevent hypoglycemia. Once the child is stable and shock has resolved, gut perfusion is good, and there's no concern about gut function, enteral nutrition should be started. Blood and blood products should only be transfused when clinically indicated. Blood or fresh frozen plasma should not be used just as volume expanders. In children who develop acute kidney injury with fluid overload, earlier initiation of renal replacement therapy is associated with better outcomes. Routine use of plasma exchange, intravenous immunoglobulin, stress ulcer prophylaxis, and DVT prophylaxis is not recommended. Also, acute repletion of minerals and vitamins is not recommended. In summary, sepsis is a leading cause of death in children worldwide, and we have to tackle it in order to achieve our SDG 3. We must actively screen children for sepsis for early diagnosis and improve outcomes, and our protocols must be adapted to the clinical settings. And in all of this, we must adhere to our infection prevention control protocols and antimicrobial stewardship programs to prevent healthcare-associated infections. Thank you for your attention.
Thank you for the wonderful presentation. I hope you can hear me very well.
You're a little quiet, Ida.
Sorry. I'm not sure if you can hear me very well.
You're a little bit quiet, Ida.
Sorry, it must be my network. Sally, could you kindly
Hi there, Ida. Do you want me to maybe just take over just help out with questions, or ask people if there are any questions, or address any questions to any of the speakers?
yes, please.
And please place if there are any questions, either, we're a small, intimate crowd of 12 people. So if you'd like to ask, you're most welcome to unmute yourself and ask us some questions if you'd like. But thank you to all the speakers. Is Charlene online or not? Charlene. Not seeing Charlene. Not seeing it is a message. Okay. I'm not seeing any questions, no hands. Lincoln, anything from your side you'd like to add?
I just maybe an apology for the sound quality of my presentation there, but it's striking that your presentation, Shamil, and mine seem to mirror the disparate incidents and outcomes of sepsis. And there is definitely a socio-political component to our advocacy. And I'm just wondering whether any of the participants or other panel members would care to comment about those aspects of our care for children with sepsis.
Yeah. No, you're absolutely right, Lincoln. And there's that song, money can't buy you love, but it can buy you good health care. So, and access to health care.
Sorry, I can't find my hand buttons on my iPhone as I'm dialing into this. Is it all right if I speak?
Absolutely, go for it. Do you want to introduce yourself? And
my name is Manal Alasnag, and I'm a pediatric intensivist. I'm background from Yemen, that currently work in London in the UK. So very different. And I trained and I worked in Saudi Arabia. So lots of what you're saying about social sort of nuances that affect outcome of sepsis are resonating, I think, and resonate with many of us that have practiced in different parts of the world. My comment was really with PICS, whether we can share some of this with the service, with the Sepsis Alliance, and some of the sepsis sort of on the sepsis in September, when everybody sort of celebrates sepsis and awareness and so on. If some of these issues can be highlighted even more. So just brilliant presentations. Thank you for sharing.
Thanks for those comments, Manal. And I'm sure Brenda is involved with the Global Sepsis Alliance as well. So I'm sure there'll be lots of sort of awareness and lots of discussion in the meeting later in September. There was a question from Ida. Let's just go into the questions. Shamil, my takeaway is that training can greatly improve outcomes for children with sepsis. And absolutely, Ida. So it's about an awareness of sepsis, knowing what to be looking for. And it's quite difficult. I mean, I think I said it earlier. Is that we've struggled over the years to come up with a definition, because it can be quite a slippery diagnosis. And when you're reassessing children continuously. It's not something a kid coming in with a name tag saying I've got sepsis, but it's a response to therapy. It's how the body responds to an infection, and you don't quite know where they're going to progress to. But awareness, education, screening tools, I think Charlene mentioned as well, and constant reassessment of children. Nick asked the question, what nursing adaptations have you made in Johannesburg or Ghana to account for children who may be arriving from far away with minimal treatment? Any comments from Stephilia? Do you want to answer
I don't
that?
know if okay, hello. I think the issue is, the difference is, if you're working in a hospital, remember that every time you come, hospital is well staffed with doctors and everything. Hence, I said in my recommendations that when we do campaigns, I think where these mothers start, where they start is going to be at the local clinics and everywhere. But in the hospital, you find that people are covered because there are medical doctors as soon as the patient comes in. So what we have to reinforce is just that in the wards where maybe the doctors are not there, people must start knowing that once you see these signs and symptoms, even if there's no doctor, give a doctor a call to say, I'm suspecting that this child is changing, looking at those signs and symptoms. But in the clinics where they start, has someone mentioned that they might be messed up? Someone thinking that because of the pile up on the shortage at the clinics, if the child comes with a cough, maybe they're concentrating on cough and not thinking that this child might be septic, because now there's a lot of queue, there's a long queue. So it's concentrating on the long queue more than on doing thorough examination. So hence I said, if we give them more of education and with protocols to say, whatever that they're doing, they mustn't jump into treating until they get a proper history. I don't know if I'm answering what I was asked.
I think one of the differences that I've seen is definitely when children are sent in from community health clinics, if they've identified as being seriously unwell, then they're given an intramuscular dose of ceftriaxone, sort of a broad spectrum antibiotic. So an early dose of an antibiotics, because you don't know how long it's going to take for that child to be transported through the healthcare system to be seen at a medical facility. So I think early recognition in the communities, early antibiotics, and constant reassessment is essential.
I think, sorry, one other thing that we have to remember is we're dealing with, I'm sure it's you who was showing the demarcation, that the other side it will be the low socioeconomic people, and then the other side is okay. So if you are like catering a bulk of people coming from a low socioeconomic, people always have this, the cultural beliefs is still there in their brain that they'll start somewhere. They not come straight to the hospital or to the clinic. They start believing in witchcraft and all those kind of things. And so they will start using things before they come. By the time they come to the clinics, it's always late.
Absolutely right, Stephilia. So they'll often use a traditional treatment. There'll be a delay in treatment. So when children do present, they're in extremis often and in need of resuscitation, and I think there's probably, when we're looking at causes of death and real incidences of mortality, I think we're vastly underestimating how many children die from sepsis because they just don't present. They die before they arrive in hospital. I'm seeing a comment from Brenda that it's everybody's business. It's about education. It's about awareness. Any more questions? Any more questions?
Sorry, can I say something?
Absolutely.
I think sometimes it's time now that we have to collaborate with traditional healers. We have to start collaborating because we can't just blame them all the time or something. Because I mean, I always see even normal people that are educated, if they go and consult, they're expecting to be well on the first day after they started medicine. And to me, by the time you see the disease, you start having the symptoms, it means this thing started so many days ago. So you cannot expect to be well after taking medication for a day. So now what we are saying is people do consult. Maybe it was okay to consult to the traditional healers, but they will say take medication by a teaspoon. They take an overdose because they are thinking that it's going to treat them well. But if we're talking about the sepsis, I think traditional healers have to know about, we teach everyone, even them, to say, in case someone consult, having, I mean, touching, you can see this child is hot, the child is floppy, they must start saying no, take the child to the hospital.
Yeah. That's a very valuable point, Stephelia, is that I think we need to incorporate traditional beliefs into healthcare practices, and sort of acknowledge sort of the existence of a large, I think the majority of people definitely in Cape Town will seek traditional healthcare first, and really only when that doesn't work will they connect to community healthcare clinics. But we definitely need to be working in hand with traditional healers. Any more questions for the panel? Is there a time limit, Ida, just in terms of when the meeting ends? 6 p.m. Okay, so I think we've got a few minutes left. Any last comments or thoughts? I'm seeing an old friend on the call earlier. She's left, Kathleen. Are you still on the call? How are things in Johannesburg? She's gone. Uche, nice to see you. So
Thank you.
So really just to end off, and my huge thanks to Ida for keeping us all on track for getting all our talks ready and for organizing this meeting. Brenda, thank you for the invitation, and to WIFPICS for hosting this African Sepsis Awareness Day, or our PICU Awareness Day.